Good morning. My name is Michael Gitlin, and it is my honor and pleasure to introduce Dr. Katie Unverferth as our Grand Round speaker today. Dr. Unverferth is an assistant clinical professor here at UCLA in the Department of Psychiatry, and she specializes in reproductive psychiatry and women's mental health. She directs the Women's Life Center, one of our oldest clinics within our department, and is also the medical director of the UCLA Maternal Mental Health Program. Katie earned her medical degree from Georgetown, where she was AOA, and then completed a residency here at UCLA, where she served as chief resident in reproductive psychiatry. She was a resident in the mood clinic during her PG4 year, and that's where she and I got to know each other. And then she was a fellow in mood disorders from 2019 to 2020. Academically, she's done a lot of things working in the psychiatry component of the comprehensive menopause program, creating the PMDD module for the National Curriculum for Reproductive Psychiatry. She's been the faculty lead for UCLA Women's Mental Health Concentration and has been a national examiner in the area of reproductive psychiatry. Katie is also a very serious clinician with a practice at UCLA outside of her work, practice in the community outside of her work at UCLA. And gradually over the last number of years, she has developed a national reputation in women's mental health and lectures nationally and consults to pharmaceutical firms. Personally, as a teacher, there is truly no greater joy than seeing one of your students, one of your professional children, develop into a colleague, a friend, and a star. And that's the way I feel about Katie. And I couldn't be more proud and more thrilled to have her as a colleague and a friend, and to introduce her today in her lecture called Novel Treatments for Postpartum Depression.
Hi, everybody. I'm Dr. Katie Unverferth. Thank you so much, Dr. Gitlin, for the beautiful introduction. Like Dr. Gitlin said, I am a reproductive psychiatrist who specializes in women's mental health. Here at UCLA, I'm the medical director of the Maternal Mental Health Program and the director of our Women's Life Center. Today, we'll be talking about postpartum depression, but what I don't want to do is go over all of the information that you already know. So what I'm going to try to highlight and focus on are nuances that I find particularly interesting about postpartum depression. We'll talk about novel treatments for postpartum depression. We'll talk a lot about the etiology of postpartum depression, because that really informs some of the newer treatments that are available. And we'll go through it step by step. So disclosure is that I'm a consultant and on the Speakers Bureau for Biogen. Objectives we've covered. One thing I do like to say at the beginning of this talk is I think it's important to speak about language in women's mental health. What I think is really important is to be precise. So most of the studies that I'm going to go over today are in cisgendered women, so people who were born female and identify as a woman. So I will use that terminology primarily, but as a field, what we're really trying to do is move towards a gender additive approach. So it's using gender neutral language alongside the language of womanhood, and it promotes inclusion while also not erasing women. And we also want to make sure that we still identify and acknowledge that certain groups experience worse health outcomes because of the intersection of their race and gender. So this is sort of what we do. So that's what I'll use today, okay? So background. So to start, and I think what's really important to frame this talk is that over the lifespan, women are twice as likely to experience depression as men. This difference starts at puberty, increases during the perinatal period, and then disappears after women go through menopause. It probably disappears a few years after women go through menopause. It used to be thought that at the final menstrual period, hormones were done, but it seems like actually the ovaries are probably sputtering a little bit and releasing hormones still for the first few years after menopause. This is important because this brings us to this idea of a hormonal subtype of depression. So what it's thought is that women have depressive episodes, a certain subset of women have depressive episodes due to abnormal mental health responses to normal levels of changing hormones. So what this gets us to is this idea that there aren't absolute hormonal level differences between women who have postpartum depression or not. But instead, what we think is that the change in level of hormones triggers a depressive episode for some people. So the conditions that are associated are, of course, PMS, premenstrual dysphoric disorder. You can think of premenstrual dysphoric disorder as depression in the luteal phase of the cycle. Hormonal contraceptive associated depression is interesting. It seems like the same people who get depression when they take combined oral contraceptives or any hormonal contraceptive probably have an independent risk factor for postpartum depression, that can actually be used to stratify risk. Depression in pregnancy, postpartum depression, depression after weaning from breastfeeding is really interesting. So sometimes what I'll see in my practice is someone's been sort of chugging along during pregnancy, doing okay with breastfeeding. When they wean, that's when they'll have a depressive episode. And interestingly, because of the prolactin interaction with dopamine, we've also seen mixed or manic episodes with weaning from breastfeeding. There are a few case reports of it. And in our clinic, we saw one person with a hypomanic state. Perimenopausal depression and anxiety as well. And it seems like the people who have these, it kind of clusters together for them. So the same person is very likely to have all of these things. One other thing that I think is really important to frame sort of why this talk is so important and why I want you all to feel empowered to treat postpartum depression is that the maternal mortality rate in the US greatly exceeds that of other developed countries. The rate for Black women is over 3 times that of white women in the US. And what you can see is that other countries listed here, they have universal health care, they have paid guaranteed leave, there's more support for the mom, there's childcare, and we just don't have that in the US. And so we see that US Hispanic women, US white women, and then US Black women have much higher rates than the rest of the world, and US Black women are really bearing the brunt of that burden. These are the updated maternal mortality statistics from 2023. These were just released in February. And so what we see is that reassuringly, the maternal mortality rate has returned to pre-pandemic levels. This big spike is from COVID. But what we see is that inequities remain. So Black women continue to have very, very high rates. White women, it actually decreased a little bit. Hispanic women, it decreased a little bit. Asian, it decreased a little bit. And then for Black women, it went up. This wasn't statistically significant, but I think it's still notable. The reason that I talk about this is because suicide is one of the leading causes of maternal mortality in the perinatal period. Mental health conditions as a whole, so if you also include substance use, is the leading cause. So this is why it's so important to talk about it, and why I want to empower you is because this is where, as psychiatrists, we can intervene to lower the maternal mortality in the US. Suicide accounts for about 20% of postpartum deaths. And it's a very important time to screen and treat psychiatric diseases. So essentially, any patient that you see that's going through pregnancy and postpartum in a psychiatric clinic is at risk of having depression in pregnancy, postpartum depression, and you need to watch them carefully to just check in on their suicide risk. Let's move on to epidemiology. So internationally, the prevalence is estimated to be about 17%. In the US, it's about 12%. What they'll say is 10 to 15% of women will get postpartum depression. Europe has the lowest prevalence, probably because of the social factors we've discussed before. And then rates tend to be higher in countries with lower socioeconomic status. What's really important to know, though, is for those with a prior history of affective illness, the rates are as high as 40% for postpartum depression and 75% for the entire perinatal period. So people who have had depression are likely to have depression in pregnancy, are likely to have postpartum depression. And when I say perinatal period, just so everybody's totally clear, I mean during pregnancy and the postpartum. Touching on the racial disparities in postpartum depression, so immigrant and minority women have higher rates of postpartum depression than other groups. It's not completely clear if socioeconomic status mediates that, but I think it is still important to know and be aware of. And there was one study that showed that Black women were noted to have symptoms at twice the rate of white women and were less likely to seek treatment. And then what's really sad is that even if Black women are screened, they're less likely to be referred to treatment, less likely to receive evidence-based care, and are less likely to receive psychoeducation about the condition. So it's a systemic issue, right? Something to be aware of, really important to intervene. Okay, let's move on to risk factors. So like I said, depression in pregnancy is one of the biggest risk factors for postpartum depression. What I will tell my patients is that stability predicts stability, and the inverse is also true. So if someone's depressed around the time they become pregnant, they're likely to remain depressed in pregnancy, and they're at very high risk of postpartum depression. And this fact is also how I will get people to buy into their treatment in pregnancy as well. So if someone is having active depression symptoms in pregnancy, they come to me and they're like, yeah, I feel awful, but really, I'm really worried about postpartum depression. I will encourage them to get treatment, because the best thing we can do is have them feeling healthy, well, euthymic, to help hopefully circumvent postpartum depression. But depression in pregnancy, one of the biggest risk factors. Other risk factors, of course, hormonally associated depressions. So all the ones we've talked about: family history of postpartum depression, personal history of postpartum depression, fetal or newborn loss, newborn in the NICU, low social support, preterm birth, traumatic birth experience, I think is important to know about. So with traumatic birth or pregnancy complications, the rates of postpartum PTSD go up to about 15%, and it increases the risk for postpartum depression. Socioeconomic status is an important predictor. One that I think is really interesting is that season of delivery increases the risk for postpartum depression. So if you deliver when the days are shorter and it's darker out, you're at an increased risk for postpartum depression. Other risk factors not on here, like perinatal sleep disturbance. I think this is a little bit of a chicken or the egg thing, where it's like, is the depression causing the sleep disturbance, or is the sleep disturbance causing the depression? Yeah. This is a brief foray, but I think important and not something many people know, is that the contraception choice, the contraception chosen in the postpartum, might affect the risk for postpartum depression. So because estrogen interferes with milk production, people don't typically take combined oral contraceptives, meaning estrogen and progesterone, when they're breastfeeding. Instead, they're often offered progesterone-only hormonal contraceptives. But it seems like in general, synthetic progestogens are not great for mood, and for susceptible people, might cause depression. So progesterone-only depot contraceptives, what they've looked at is norepinephrine and medroxyprogesterone. Both seem to increase the risk of postpartum depression. So because of this, we don't typically recommend the mini pill for someone at risk of postpartum depression. You could use progesterone-only IUDs, and those are generally tolerated better. But there is a dose response where the higher the dose of progesterone in the IUD, the higher the risk of depression, but the absolute risk is still very low. But just something to be aware of, that if someone's at high risk, they want a progesterone IUD, just encourage them to get the one with the lowest progesterone. The one that I might choose that came on the market fairly recently is drospirenone. Drospirenone is a newer progesterone. It's the same progesterone that's used in Yaz and Yasmin that have the FDA indication for PMDD. So they just made it with the drospirenone only. And it's not seeming to be associated with mood worsening in the postpartum. There was one study that showed it might actually improve mood in the postpartum, but I think it's too early to say that. Mostly what we're looking for is not to worsen it. So that could be a good option, and something to counsel your patients on if you're seeing a lot of postpartum women. Symptoms and diagnosis. So postpartum depression is typically a very anxious depression. Anxious distress is very prominent. They have high rates of rumination and worry, lots and lots of circular thinking. So like, am I okay? Is the baby okay? What's going to happen? Intrusive thoughts are very common. There are some studies that show that almost all women have intrusive thoughts of accidental harm coming to their baby, and about half have intrusive thoughts of intentional harm coming to their baby, which is so distressing, right? If you're a new mom having an intrusive thought, if you have no touch with with the field of psychology or psychiatry at all, and you have a thought that you're going to stab your baby, that is terrifying. People think they're going crazy. I've had many a person call me and be like, think I'm psychotic because I'm having these thoughts. You know, what happens sometimes too is that the family support system actually enables them to avoid caring for the infant because of the intrusive thoughts. So I've seen cases where the infant is living with the in-laws because the mom is having such bad OCD and intrusive thoughts, and nobody really understands that the intrusive thoughts are ego dystonic. They're not going to harm the infant. Probably the best thing we can do is keep them together. Feelings of being overwhelmed is very common. Mood lability. So people really identify with this feeling of postpartum rage. So they just feel so dysregulated. Anxiety is often focused on babies or mother's health. So what you can see is like, they'll be like, the baby looked at me funnier. I don't know if they laugh a lot. I think they have autism, but there's no evidence that they have autism. Their pediatrician doesn't think they have autism, but the mom can't stop thinking about it. We see a lot of checking behaviors too. So checking like, are they laughing right? Are they laughing right? I had a really successful woman who was really focused on if she thought her son had an anxious attachment or a secure attachment to her. And so was always watching, like when she walked in the room, like, did he laugh in the way he should? Like, I feel like he likes the nanny more. So this can be really overwhelming, and it really impairs sort of the ability to be present. Being present is very hard anyway in the early postpartum, but this really gets in the way more. Lack of interest or attachment to the baby, which I want to flag. We'll come back to this. But perhaps this is some of the way that the negative infant outcomes are passed down from someone who has postpartum depression. And then suicidal ideation is common, up to 20%. They also still meet criteria for major depressive disorder. But what I see is when someone presents to you, what you really feel is like the anxiety, the rumination, the sort of crawling out of their skin. But they also identify with it's hard to feel pleasure, they feel sad, they're crying a lot. So we still use the same criteria, MDD, and what you would do is you would add the peripartum onset. Per the DSM, symptoms have to occur within 4 weeks, but clinically it's considered to be postpartum depression if symptoms begin within 1 year of childbirth. Just in practice, that tends to be what people do and how you treat. Importantly, it's estimated that 33% of postpartum depression begins during pregnancy, and 27% is a continuation. So it's like before pregnancy, continues through pregnancy, continues in the postpartum. This is important and sometimes helpful because I will ask my patients, how did you feel in the third trimester? Because I'm often seeing them in the postpartum. Sometimes if you drill down, you'll see that their symptoms started then because there are probably hormonal shifts that are happening. And there's been some new really interesting studies that progesterone metabolism might be off in the third trimester in women who subsequently develop postpartum depression. And there's some thought that certain markers might actually be used as a biomarker for postpartum depression. EPDS, I'm sure you're all familiar with it. The reason that we use the EPDS instead of a more common depression screener like the PHQ-9 is because the EPDS takes out some of the physical symptoms of depression that overlap with the symptoms of pregnancy. So EPDS doesn't ask about like sleep or energy or weight changes in the same way because those aren't very relevant when someone is pregnant and having big weight changes or postpartum. So it's a validated screening tool. Differential diagnosis. So baby blues, of course. I think a really interesting way to think about baby blues is that this hormonal change that happens, everybody, pretty much the majority of women are sensitive to it. So 75% of women have baby blues, but only some go on to develop postpartum depression. But I think it helps you understand that like this hormonal change is huge. Most people feel it. It's just that not everybody goes on to develop postpartum depression. Symptoms of baby blues, mild irritability, low mood, tearfulness, resolves at 2 weeks. What's really important to know, though, is that it's never associated with functional impairment. So if someone is having functional impairment, severe obsessional thinking, suicidal ideation, it's postpartum depression and treat appropriately. Don't wait. Sometimes I'll see in the community, especially where it's like, well, it's in the first week or two, maybe they're going to start feeling better. But if they're having severe symptoms, it's postpartum depression. Obsessive compulsive disorder, we've touched on this a little bit, but I think what can help you understand it is that when the intrusive thoughts are about the infant, they're much more distressing. And so people who previously have had like contamination OCD or like other intrusive thoughts, when the intrusive thoughts start to become about the infant, it can be debilitating. Anxiety, trauma-related disorders, especially postpartum PTSD, important to screen. Interesting things that increase the risk for postpartum PTSD is dissociation during delivery, emergency C-section, feeling out of control, or perceiving the care as incompetent or uncaring. So kind of, if you've heard people who have had it, like emergency C-section, often part of it, and then feeling like they don't have any choice in the matter. Like they don't have a choice, they have to do this, or the perception, it can be often they don't have a choice and they perceive that care to be uncaring. Other differential diagnosis, bipolar disorder, of course. There's a really interesting study that shows that of those who had a depressive episode as their first episode of bipolar disorder, about 12% had postpartum depression as the first episode. So not a huge number, but enough. So some people who you're seeing who have postpartum depression will ultimately go on to develop bipolar disorder. And then in one study, about 1/3 of women who screened positive for postpartum depression on the EPDS actually had bipolar disorder. This is more for your obstetric clinics where maybe the only screening they're doing is an EPDS. Here, I expect that we would sort of understand more of the diagnostics. Postpartum psychosis, rare, but there are a few things I really want you to know. It's that postpartum psychosis doesn't present like your typical psychosis. So it's a triad of cognitive, mood, and psychotic symptoms that wax and wane. And why this is important is that it's thought that perhaps during a period of lucidity, when the person doesn't look psychotic or disorganized, that's when perhaps the family leaves them alone with their infant. And that is perhaps when infanticide occurs, because we know that there is a risk of infanticide with postpartum psychosis. So it's a psychiatric emergency. They should go to the ER. I think collateral is so, so important because, again, it's these periods of lucidity that make it so dangerous. So if someone goes to the ER and they look mostly fine, but the family is saying they've been really psychotic, they should still be psychiatrically hospitalized for monitoring. Okay, so why do we care about postpartum depression? So the first is that it can develop a chronic course without treatment, right? So 30 to 50% of women will have major depression into the first year of their child's life. That's a long time. That's a lot of women. It's very hard to have an infant. I have a 1.5-year-old, right? So I can't imagine being depressed for the majority of the first year, right? Another study followed women who had an index episode of major depression, so their first episode of major depression ever in the postpartum for 13 years. About 33% had sustained remission, which is pretty good. But 20% reported being depressed 50% of the time. So for some people, postpartum depression is really the beginning of a lifelong illness. And then remember, those who have had postpartum depression before are at high risk of relapse in subsequent pregnancy. So this is why we need effective treatment options. The other reason, so there's not just the impact on the mother, there's also the impact on infant development that's so important. So people will say that postpartum depression affects 2 generations. So with infant development, what we know is that over and over and over again, postpartum depression has been associated with impairment of cognitive function, behavioral disturbance, poor physical health, insecure attachment, and depression in the offspring. And what we know is that the more chronic the postpartum depression is, the higher the risk of these things. So again, this is why we want to intervene, really want to encourage people to seek treatment. What we also know, and what I talked about earlier, is that it's sort of easy to imagine how this occurs, right? So in depressed mothers, when you're depressed, right, you're internally focused. It's very hard to respond to the outside world in a normal way. And infants develop in relationship to another person, right? So if an infant coos, you coo. If they do like a little smile, you do a big smile and you lean in. If they say something that sounds like a word, you're like, oh my God, hi, you said hi, right? There's this interaction that's required to help develop an infant's brain. And what we think is that depressed moms, that's much more difficult and probably occurs in a lesser way. Other things, they're less likely to breastfeed. There was one study that showed that women who are depressed and breastfeed experience breastfeeding as more painful and have less of an oxytocin bump. So it's both less rewarding and more uncomfortable. So perhaps that's why they stop breastfeeding. They're less likely to attend well child visits, complete infant immunizations, use safety devices, or place the infant on their back to sleep. The way that I read this is their resilience is very low, and it's very hard to do these things. Yeah, so I think this is why it's so important to treat. It's so important to pay attention. The other thing to know, and another way to intervene, is that if you are treating a new mom for postpartum depression and they're partnered, it's very important to check for depression in the partner. So all of these studies have been done on men, so like heteronormative couples. But what they found is that the incidence of paternal postpartum depression in men when a birthing parent had postpartum depression is 25 to 50%. So really high risk if one person has postpartum depression. The reason this is important is because having a euthymic caregiver, parental figure, friend, anybody in the home helps mitigate the risk for the neurodevelopmental issues. So that's why you screen for the partner, or if the person's really depressed, encourage them to call in all of their favors, right? Call their friends, call their family, whoever can come and help, because that'll be better for the infant. Okay, etiology, so into some fun stuff now. So something you might not remember from med school, right, is that the hormonal change in pregnancy is really second only to puberty. These are huge, huge hormonal shifts, right? So estradiol increases by 50 times by the third trimester compared to maximum menstrual cycle levels. Progesterone increases 10 times. Most women are sensitive to this change because the majority get baby blues, but only some go on to develop postpartum depression. So again, this subset of women who's sensitive to the changing levels of hormones. Individual susceptibility is more important. And there's this classic study by Block where women were giving pregnancy mimicking doses of estrogen and progesterone, and then those were slowly withdrawn over 4 weeks. And what they found is that those who had a history of postpartum depression had depressive symptoms and an increase in cortisol. So certain women, what it seems like is the brain of certain women don't accommodate this hormonal change. And we have some ideas as to why. So this is just the hormonal change illustrated up, down. Another theory for this, the etiology of postpartum depression is HPA axis dysregulation. So we know that adverse childhood events, history of stressors really rewires the brain in a way that the brain subsequently responds to stressors in a different way. So this probably also increases the risk for postpartum depression. Stressors that occur specifically in the postpartum have the greatest effect on risk, but any lifetime stressor can affect risk. Stepping back and looking at PTSD too, sometimes what we see is that people who have had PTSD before, being pregnant can really activate it because there can be very invasive procedures like transvaginal ultrasounds. There can be, you're having to get undressed frequently. There can be pelvic exams. So for some people, especially those with a history of sexual trauma, pregnancy can be very difficult. And then delivery, depending on the type of care provided, can also be very difficult. So sometimes that in and of itself triggers PTSD. But also what we see is people with PTSD, when they have this adorable little infant, they think about how vulnerable the infant is. They think about how vulnerable they were, and that can really trigger PTSD. Pregnancy is typically associated with blunting of the stress-induced activation of HPA, and the inability to suppress this is associated with postpartum depression. GABA glutamate dysregulation is the interesting one that also informs the mechanism for zuranolone. So allopregnanolone is a progesterone metabolite that works on extrasynaptic and synaptic GABA A receptors. It's a positive allosteric modulator. So progesterone and allopregnanolone go up, and then they drop off rapidly in the postpartum. Allopregnanolone, as a positive allosteric modulator at GABA, has calming effects. So think benzodiazepines, think alcohol. What's thought is that the rapid withdrawal from allo, so it goes up, it's calming, and then it drops off rapidly. Perhaps that drop off, that withdrawal from allopregnanolone and the failure of GABA A receptors expression to compensate can lead to postpartum depression and an abnormal stress response, which makes sense because GABA regulates the HPA axis. It helps regulate the stress response. So what we think is happening, this is preclinical data, meaning it's animal models. But what they've shown is that as allopregnanolone goes up in pregnancy, the GABA A receptors upregulate to accommodate that. That's why you're not just totally zonked during pregnancy, right? And then what happens is in the postpartum, as allopregnanolone goes down, it's possible that GABA A receptors are not downregulating in the way that they should. That's one of the theories for postpartum depression. And then PAMs of the GABA A receptor, because they work on both extrasynaptic and synaptic receptors, act as a treatment for postpartum depression and help restore this GABA glutamate balance that gets off. This is just the same thing illustrated. Great, so let's get into treatment. So always start with non-pharmacologic treatments for postpartum depression. So of course, cognitive behavioral therapy, interpersonal psychotherapy are evidence-based for postpartum depression. Peer support, you might use peer support in group settings more in postpartum depression than you would at other times. That's because when you're learning how to be a mother, it's really helpful to see other people being mothers. So learning through modeling is a really important thing. And I think historically people have sort of raised babies in groups, and now we're much more separated. Exercise is a good recommendation, but people sometimes get pissed off if you recommend exercise when they're 6 weeks postpartum because you don't have any time. So while it's evidence-based, if someone has the resources to be able to do that, that's great, but it's not always very feasible. And then sleep is something where I bring the partner in or any family member who can help. And what we do is we really strategize about how can we get you more sleep? What can we do? Who can give a bottle overnight? Should we consider combination feeding? Really thinking of alternative ideas to get them sleeping more. Historically, first line for postpartum depression has been traditional antidepressants. So SSRIs have evidence that they help for postpartum depression compared to placebo. They have a good safety and tolerability profile. Postpartum depression is considered a subset of major depression that has specific triggers, so we use SSRIs. If someone has never been on antidepressants before, you would typically use sertraline. It has low placental transfer into breast milk, and it's a good option for those who've just never taken an antidepressant. But we have a lot of safety data for most of the commonly used antidepressants. So if someone has tried many different antidepressants, venlafaxine was the one that worked best for them, they're just off it right now, I would just restart venlafaxine regardless of if they're breastfeeding or not. So you don't need to reinvent the wheel. You don't need to feel like you can only use sertraline. We have a lot of good data. And just touching on this slightly more, the relative infant dose of less than 10%, so that's the maternal weight adjusted dose, of less than 10% is typically considered compatible with breastfeeding. Most antidepressants are below that. The only medications we use in psychiatry that are above that are lithium and lamictal. But other than that, typically our medications are low levels in breast milk. There was a really beautiful review paper that essentially showed that most national and international society guidelines recommend encouraging breastfeeding independent of the antidepressant used. The reason we treat with antidepressants is because it improves outcomes both for the infant, the family, and the mom. So what we saw is that treating with SSRIs resulted in improved maternal depression symptoms at up to 5 years postpartum, improved maternal relationship satisfaction up to 5 years postpartum, and decreased risk of child externalizing problems and ADHD up to 5 years. So really important, and we know that intervention helps. I think that's why it's so important to treat. Moving on to neurosteroids. So neurosteroids are the new player in the postpartum depression field. Zuranolone and brexanolone are synthetic preparations of allopregnanolone. So allopregnanolone is the one we talked that works on the GABA-A receptor. They modulate at synaptic and extrasynaptic receptors. They have a calming anxiolytic effect. Sometimes they're too calming because you can be very, very sedated with these medications. We'll talk about it. Zuranolone is orally bioavailable, dosed once a day for 2 weeks, and then brexanolone is no longer commercially available, but when it was a 60-hour IV infusion. So evidence of efficacy for zuranolone comes from 2 clinical trials at doses of 30 milligrams of 50 milligrams. 50 milligrams is the dose that we use for postpartum depression. It has efficacy as a add-on or monotherapy, which is nice. So you have some flexibility there. Clinically significant and statistically significant improvements are seen in anxiety and insomnia. They've done some post hoc analysis. And then 50 milligram once daily versus placebo had meaningful improvements in depression scores at day 3 versus placebo that were sustained until day 45. We don't have any data after day 45. The study inclusion criteria, the only things that I'll really highlight is that 15% were on concomitant antidepressants. So a decent number were, they just had to be on stable doses. And then sertraline and escitalopram were the most common ones. But then they excluded people who had bipolar disorder, psychotic disorder, or really severe postpartum depression with suicidal risk, or who had attempted suicide. And here's the data illustrated. So what we see is that there's a separation from placebo as early as day 3 that's sustained until day 45 with active treatment of zuranolone 50 milligrams. We see this illustrated again with response and remission. And so overall, zuranolone has fairly good evidence for postpartum depression. Generally, it's well tolerated. The big side effect is somnolence, as you might guess, and fatigue. For those who are wondering, somnolence is the feeling of sleepiness, whereas fatigue is more like physical exhaustion. They're distinct. It's not recommended to drive for 12 hours after dosing because the CNS impairment is so significant. There's no increase in SI in clinical trials. Though in one, I had one patient who had an increase in self-injurious behavior urges while she was on zuranolone. No withdrawal side effects. So the way you prescribe it is a little obnoxious. So it comes in 20, 25, and 30 milligram capsules. So you have to prescribe 2 25 milligram capsules to a specialty pharmacy. If that's too sedating for them, it's recommended to lower to 40. So you have to re-prescribe 2 20 milligram capsules. So what happens sometimes is if you have to dose lower, there can be sort of this gap in care while you're waiting to get them the new prescription. It's classified as a Schedule 4 controlled substance. The abuse potential is comparable to alprazolam, though in practice this doesn't really concern me because even if someone loved zuranolone, they're not able to get more zuranolone. And again, N of 1, a different patient who had chronic benzo use before she started zuranolone, took zuranolone and her benzo use decreased afterwards. So it didn't seem to like trigger cravings in of one. We don't have studies in this population really. Here are the side effects. So only about 2% discontinue because of side effects and 14% dose reduce at the 50 milligram dose. But again, somnolence, dizziness, diarrhea, fatigue are the big ones. The COVID-19 and COVID-19. Zuranolone and breastfeeding. So this is an area where we need more research. We don't have any data on effects of zuranolone on a breastfed infant. What we do have is one small pharmacodynamic study with a dose of 30 milligrams daily, which isn't the recommended dose, that showed a very small relative infant dose of less than 1% and a mean relative infant dose of 0.357. What they did is they extrapolated that data out to the 50 milligram dose, and they expected that the level in breast milk would still be very low. So overall, that's reassuring. Generally, we consider this to be compatible with breastfeeding, but in practice, I haven't had any patients who have chosen to continue breastfeeding and take zuranolone. They've either stopped breastfeeding or they have come to me not breastfeeding already. In clinical trials, they had people avoid breastfeeding for the duration of the treatment dosing, so for 2 weeks and then for 1 week thereafter. Zuranolone versus a traditional antidepressant. So there are no head-to-head comparisons, but what they did is they did a matching adjusted indirect comparison between zuranolone and SSRIs. And essentially what they found is that there were larger reductions in depression symptoms as measured via EPDS, the Edinburgh Postnatal Depression Scale we talked about, from treatment day 15 to day 45 for zuranolone treated versus SSRI treated. To me, I think this is interesting, but it doesn't mean very much because SSRIs take so long to get to an effective dose, whereas with zuranolone, you're on an effective dose at day 1. So I don't think this means that SSRIs aren't effective, and certainly for patients with comorbid conditions, we should still be using SSRIs. Factors to consider, the main questions I think that remain are, breastfeeding, cost, access at UCLA at least, with the private insurances we see here. I haven't had trouble getting it approved, but I know that that's different in other parts of the state. The real question is, are we going to need an antidepressant to maintain the response to zuranolone? And we don't have the answer to that yet. Brexanolone, no longer available on the market. The main problem was that it was a 60-hour IV infusion in a monitored setting, and it was very expensive. So it was hard logistically to find a place for it. And it's not commercially available anymore. This is Sage removing it. Okay, so here is my algorithm for treating postpartum depression. So for mild postpartum depression, you would start with psychotherapy, encourage them to sleep more, maybe go on walks if they can. For moderate postpartum depression that has failed psychotherapy or severe postpartum depression, then we're thinking about medications. And here what we want to do is we really want to separate out, does this person have comorbid conditions that also need treatment, or do they only really need treatment for the postpartum depression? The way I think about zuranolone is that the way that I think about it, the way I tell patients about it, and the way I tell sort of my residents to think about it is it could get you back to your pre-pregnancy baseline. But if your pre-pregnancy baseline was kind of crappy or you needed treatment then, zuranolone's probably not a medication for you. So for someone who has a first episode depression, but then you also find out that they have untreated GAD, OCD, PTSD, or personality disorder that requires treatment, I would put them on an SSRI. It's OCD that's the one that I see a lot, sometimes PTSD too, where again, it's been sort of quiet and simmering. They might have had periods of functional impairment, but they've never really received treatment for it. And then in the postpartum, it's the time where they really need to. We also know that in the postpartum, you just have so much less time for all of your coping skills. So you can't go to yoga, you can't do breath work, you can't go on runs, right? You can't go see friends, especially in the first few months. And so that can be very difficult. If they have no comorbidities that require treatment, and it's their first episode of depression, I would use zuranolone. I don't see very many of those patients. Everybody that I see is already on a medication. OBs are typically seeing those patients. And interestingly, it looks like OBs are the primary prescribers of zuranolone right now. If zuranolone is ineffective, go to an SSRI. If it's a recurrent episode of depression, I would probably use medications that had worked before. Like if venlafaxine had worked before, I would probably do venlafaxine again. But you could discuss zuranolone as an alternative. Other option is if they're on antidepressants, which is what I see. So someone who's sort of been on fluoxetine 20 for like the last decade, they were doing well during pregnancy and then the floor just kind of dropped out from underneath them in the postpartum. In that person, I would have a conversation with them about whether or not they want to increase the Prozac or do they want to try zuranolone. My hunch is that even if we did zuranolone, a lot of times we would still end up needing to go up on the fluoxetine a little bit. Okay. Moving on to investigational treatments for postpartum depression, there's some fun things in the pipeline. So TMS has been investigated for postpartum depression. I spoke with our very own Andy Luchter about this. And so in so much as postpartum depression is a timed major depression, is a major depression that happens at a specific time course, there's no reason to think that TMS wouldn't be effective for it. Typically, when I refer to TMS, it's either people who have had many side effects before and don't want to take a medication. Or they have something comorbid that TMS could also treat, like OCD, chronic pain, migraines, those types of things. But we do refer to TMS, especially when they're enrolled in like the perinatal intensive outpatient at UCLA. Sometimes they can do that at the same time, where they go get the TMS in the morning and then they come to the program. Other things being investigated, it's interesting, is ketamine. So ketamine hasn't been researched as a treatment for postpartum depression. What they've done is they've sort of given it for C-section and then seen what happened with depressive symptoms. So like how it's been used in the literature mostly is ketamine for anesthesia for the C-section, and they found that it had a positive effect on depressive symptoms. This is the newer study. It looked at giving a ketamine infusion after childbirth to women who had mild depressive symptoms in pregnancy. So they didn't have moderate or severe, they just had mild symptoms. And what they found is that a 0.2 mg per kg S-ketamine infusion over 40 minutes had improvements in depressive symptoms. So, of course, the side effects, though, sedation, dizziness, double vision, but otherwise it was well tolerated. So interesting if this could be a hospital-based intervention eventually, because we certainly know that there are a decent number of people who are depressed in the third trimester. Psychedelics. So psychedelics are interesting. So in so much as postpartum depression is a disconnection from the self, from the infant, from supports, with depression symptoms, right? Low mood, reduced self-compassion, there's lots of guilt, lots of ruminative thought, reduced maternal role gratification. Perhaps there's a role for psychedelics. There's one psychedelic that I'm aware of that's in phase 2 clinical trials. It's a psilocybin derivative that has a shorter half-life. So it lasts in the system for 3 to 4 hours. And it's being investigated for postpartum depression. So it's Reunion Neurosciences. It's interesting. So we also know that psychedelics just help with depression. It'd be interesting if we can kind of see how they might have like specific utility for postpartum depression. Okay, and then a case example. So this was a patient I saw in the perinatal intensive outpatient program. This was a woman in her mid-30s with history of severe extensive trauma. So torture, abuse from siblings and father. Brief therapy in college, but otherwise was treatment naive, which was incredible. This was an incredibly resilient person. Supportive partner works as a physical therapist. She had a miscarriage in 2023, got depressed afterward, then got pregnant quickly again, and then felt the depression somewhat improved with the pregnancy. But then she had a very traumatic birth. Her epidural wasn't working, so then she had to switch to spinal anesthesia, had trouble breathing, thought she was going to die, which really reactivated her PTSD symptoms. She's felt low and overwhelmed since the baby's birth, hasn't been able to use her typical coping skills because she did a ton of behaviors. So she did meditation, breath work, yoga, exercise, right? You don't have time for those in the same way in the postpartum. And was having to physically recover. She had very vivid memories of childhood abuse, passive SI, insomnia, feeling out of touch with herself and her partner, depressed mood, anhedonia, lack of motivation. She was started on sertraline 50 by an outside practitioner and presented to me. In the perinatal IOP, she was receiving lots of therapy, so individual therapy, DBT, CBT, group support, attachment-based parenting. She said she hadn't had any improvement on the 50 milligrams daily. So what we ended up doing is we increased to 75 and we prescribed zuranolone 50 because she was having such a tough time. She wasn't breastfeeding, so we didn't have to have that discussion with her. Once she started the 50 milligrams, she said it helped with her. It helped her intrusive thoughts resolve. She was spiraling less. She felt more like herself. She felt more resilient. She did well. She had continued anxiety once off of the zuranolone, and so we ended up subsequently increasing her Zoloft to 100 milligrams daily. She was thrilled. This was a huge improvement for her. She was celebrating like holidays she hadn't celebrated before. She brought in all of these like cookies to everybody. She felt like back to herself. On admission, her EPDS was 25, which is severe depression. 2 days after zuranolone, so like day 16 of dosing, right? It went down to 18, and then on discharge from the program, it was 16. So still moderate depression, but for her, this was a huge improvement. Good. Thanks, guys. Move on to questions.
Thank you, Dr. Unverferth. First of all, those of you who are interested in, we have to get rid of this. There it is. I keep losing the. Oh, now I see it.
Oh, no, the chat's right.
Oh,
The Q&A's up here.
Under more,
Click, just,
sure.
and then Q&A.
Q&A, there we are. Great. First of all, in-person persons, do we have any questions for Dr. Unverferth? Yes, and I will repeat the questions. Dr. Flores?
If someone did well on Paxil
Mhm.
previously, is that one of the SSRIs that you would be concerned about continuing during pregnancy, or would you also continue that?
Okay, so the question is, I have to repeat it for the gang. If somebody was on paroxetine pre-pregnancy, given the controversies about it during pregnancy, is that something you would still use?
Yes. I think that there are newer studies that don't show that there's an association with cardiac defects. That being said, a discussion with the patient needs to be had because probably there will be strong reactions from other care providers. So with enough education and informed decision-making, I think you could do it, absolutely. But that is one of the medications where I think I wouldn't be surprised if people had, oh my God, you can't be on that during pregnancy, so they have to be really prepared for that. But yeah, you could. Medical legally, it's just make sure you document well. Yeah.
Great.
Thank you.
Lena?
Question about zuranolone dosing. If the recommendation is if the patient is having sedation or fatigue on the 225, so 50 milligrams, I'm wondering if there's a reason we don't start with doing the 25 plus a 30 tablet.
Like the 20 plus the 30.
Yeah, so then if they are having the side effects, then they can just go down to 220s.
That seems
So wait, so the question is, if you're using zuranolone, why not start at a lower dose and then go up if need be, as opposed to the higher dose? And if they get sedated, having to lower it, correct? Is that no?
Or starting with because you start with 225 milligram tablets, instead starting with a 20 and a 30, so you have the option to go down to 40 if you're having side effects.
That's a great idea. I haven't in the package insert, it says to prescribe 225s. And so I think it's great math, great idea. I think the main thing is will insurances cover it that way? Because right now, for whatever reason, the only reason we have the 30 milligrams is because if there's hepatic or renal impairment, you dose adjust to 30. But for whatever reason, we can talk with one of the reps and ask. Insurance would cover it. It's a great idea. Then they have a bridge. Yeah.
Third question, Chelsea.
So zuranolone is acting on the GABA A receptor,
Yeah.
like the allogranolone would. When you stop the zuranolone, do we understand why that effect is more sustained and they don't just have another kind of drop off?
So the question is, if zuranolone works through GABA A, why is it that after 14 days, the effect continues longer than you'd imagine, given the half-life?
Yes. So the thought is that in preclinical data, it's probably from receptor changes. So it's probably helping, giving that dose for 2 weeks seems to help reset sort of the receptor balance that might be off. That's the theory, because otherwise, correct, it doesn't make much sense. But it seems like giving it might sort of help reset the GABA glutamate balance and maybe the HPA. Yeah.
So in keeping with the theme of zuranolone questions, I have a zuranolone question, and then I don't have to repeat it. So the question is, biologically, side effect profile, it sounds and feels much more like a benzo or a benzo-like substance than an antidepressant. I assume there are no studies comparing zuranolone to, let's say, a benzo for postpartum depression. And has anybody looked at the rating scales and extracted the anxiety and obsessive scales? So you're just looking at core depressive symptoms to see, is this really acting as an antidepressant or is it acting as an anxiolytic? That's one of the things that I've struggled with, just having read the paper, but not having the clinical experience.
That's a great question. I think that my understanding is what makes zuranolone different is that it binds at extrasynaptic and synaptic GABA A receptors, so it's able to do more of like a long-term effect. But I don't know as much about benzopharmacology as you do.
Yeah, and the tricky part is, so what? It's still GABA. There's no evidence that other GABAergic compounds have antidepressant efficacy. That's what makes me think, well, wait a minute, maybe because remember, you did say that in postpartum depressed women, the anxiety and the obsessive stuff are more dominant than they are with classic depression.
Right.
So that made me think maybe it's really working as a spectacular anxiolytic.
Yeah.
Anyway, I'm not sure.
I think it's a really interesting question. I don't think there aren't studies looking at that. They looked at EPDS for depression, and then they did like post hoc analysis of anxiety and insomnia and found improvements, but they haven't separated it out.
Thank you. Okay, so now we'll go to some of the questions from the gang at home. First one is, any studies on military women who have decreased menstruation due to physical training, and do they have less ability to tolerate change in their hormones during pregnancy?
That's a very interesting question. I unfortunately am not aware of those studies. I'm not aware of those studies because I think you're sort of asking like if they're like athletes who have changes in menstruation, do they have a differential susceptibility to the hormonal change in pregnancy? I'm not aware of those studies, unfortunately.
Great, thank you. And then we have another question. Hi, Wa. What are your thoughts about using zuranolone as a bridge to an SSRI taking effect in non-postpartum patients with major depression? First of all, I'm not sure you'd ever get it paid for.
Yeah, no, I think that's an interesting idea. And I know, so zuranolone, Sage, when they were doing zuranolone, also went for the MDD indication, and they didn't get the MDD indication for zuranolone. So while it isn't a bad idea, it might have some efficacy. Insurance isn't going to cover it right now. Insurance is only covering zuranolone for one time per postpartum period right now.
And for 2 weeks.
And for the 2 week, so once a day, 14 days dosing. Because I've had questions of people who are asking if they can redose it because someone had a really good response in the early postpartum. Now they're 18 months out and getting depressed again. They're asking if they can redose zuranolone. And as far as I'm aware, insurances aren't covering that at all.
And I assume it's prohibitively expensive without insurance.
Like $13,000.
That qualifies as prohibitively expensive, even on the west side of Los Angeles. Question about posting the references, and I see it over here. It wasn't in the slide set.
It is in the slide set, but we can post them some. What do we do?
The presentation will be uploaded.
Okay, the presentation will be uploaded.
Yeah. There are 2 pages of.
Oh, there it is.
There are like 4 pages of references, but here's the first page.
Multiple
There are
pages.
like 45 references. So.
Excellent. Thank you. Another question, Elisa. Would you start with sertraline for depression that starts in pregnancy, or with Prozac, since there's more information in child development at 7 years with Prozac exposure? This is from a child psychiatrist colleague, of course.
If there is someone who's treatment naive and they are pregnant, the general reproductive psychiatry would start sertraline because it has low placental transfer as well. And so it's considered to have sort of the lowest exposure during pregnancy and postpartum. But if there were any reason that person should be on Prozac, like if they had OCD or they had prior response, we would absolutely use Prozac. There's not really any differentiation from a risk assessment with the SSRIs from my perspective, except if you have the choice to pick any, people will choose sertraline.
Yeah, and I think one of the dominant themes from the early part of what you were talking about is that the literature itself helps, but a history of prior response is a much bigger factor in the way you think about this than you would imagine just reading studies.
Right.
Would that be correct?
That's correct.
Yeah, and I think that's a big issue for clinicians to just remember. It's not just about studies, that common sense, clinical experience for that individual also is hugely important in creating an optimal algorithm of treatment.
Correct.
Good. Okay, any other questions? We have a teeny bit of time left, but I think we've done all our online questions. Any in the peanut gallery, anybody have any other question?
Great,
All right,
did it.
thank you, Dr. Unverferth. Thank you all for attending, and I know you can get your CME either through that, they're gonna get something, right? It's been posted already. Okay, guys, be well. We'll see you again soon.